Good afternoon and welcome to all of our community engagement groups, our advisors, our ambassadors, and our community members who have jumped on. Today is Thursday, October 15th, and this is our 29th weekly virtual meeting. My name is Deborah Volleson, and I'm the Director of Community Engagement for Kauai Delta. And some of you know that we've started our in-person meetings, and so we're very happy that for those of you who have joined us for those. But we're still offering the online virtual links for those who are not quite comfortable meeting in person yet. But I just wanted to give that little plug for our in-person meetings. I'm also really happy to be joined by Gary Herbst, our CEO. He has joined me for every one of these except for, I believe, one.
Right.
We had a couple of stand-ins, but our talent is always here, and so we are very glad that you have joined us. These webinars are just to keep you up to date on the hospital. They're not politically charged. We try not to get involved in other organizations in our community, but we are here to give you our up-to-date information. How are you, Gary?
Yes, I'm good.
Good.
We were just talking earlier that it's actually been a month since we last met. Just the timing, moving to bi-weekly and then having the town hall meeting that kind of took place of this.
Right.
And but it seems like it's been a long time, but after doing 29 of these, it's kind of like riding a bike. So I think we'll quickly get into
I don't know. I forgot half of what I was supposed to say.
Yeah.
These meetings will be posted.
Well, we'll get comfortable here pretty quick. So, but yeah, it's good to be back.
Yeah. Well, welcome.
Yeah, thank you.
So let's go ahead and jump right in. We always start these meetings giving you our up-to-date numbers. So you want to do that? Let's give the current numbers.
Yeah, got it. And obviously, we've been at this now, this pandemic, for 7 months, if not longer than that. And so naturally, the numbers are going to get bigger and bigger and bigger. Although in some respects, the numbers are getting smaller, as I'll talk about when I move down to the Kauai Delta level, which this will be really kind of one of our more positive reports. So we do have a lot of good news to share with folks. So I'll start at the state level. 16.4 million COVID-19 tests now have been performed statewide. Of those, 855,000 have tested positive. And so if you look over that 7-month pandemic, that translates to a positivity rate of 5.2%. So of the 16.4 million people that were tested, 5.2% of them over the pandemic have tested positive. On a positive note, a good note, that positivity rate has continued to decline at the state level. The state now measures at both the state level and at the county level what they call kind of the 7-day. It's a moving 7-day average. The state tracks it at 7 days and then a rolling 14 days as well. So the most current 7-day positivity rate at the state level is all the way down to 2.7%. Which is almost identical to the 14-day positivity rate of 2.6%. So the fact that the 7-day is slightly higher, 0.1% from the 14-day rate, is just that we have seen a bit of an uptick over this last week, and we're definitely, if you're like me, although I try not to watch as much news as I was watching earlier on, but we definitely are seeing increases in the virus in the United States, in the Midwest, and the Far East, New York, but then Europe is actually starting to experience a pretty significant resurgence in their positive cases. Since inception, the state of California has reported 16,639 total COVID-related deaths. And I know that continues to be a very controversial number. And I did share with folks probably at one of our very first broadcasts is that I still remember a woman that was admitted to Kauai Delta. Unfortunately, she had end-stage renal disease, meaning her kidneys no longer function, and so she had to go to dialysis 3 days a week, 3 hours per session. And she finally came to the point in her life that says, I'm just done with it. I can't live like this anymore. And so she stopped going to dialysis. And unfortunately, you can't survive if you're not having your blood cleaned because your kidneys aren't doing it for you. So she ended up eventually passing away, but she also was COVID positive. And so we clearly believe her death was entirely unrelated to COVID, but we were required to, and we share that information with the county, who then shares it with the state, and the county informed us that they had to count it as a COVID-related death, even though COVID had nothing to do with it. And so I think, that controversy still continues out there. I'll tell you, for purposes of Quia Delta formally coding the medical record, and coding, what was the primary diagnosis, what were secondary diagnoses, how we bill it to Medicare and the various payers. We actually strictly follow all coding conventions. So the only time that we code the patient as as a COVID primary diagnosis is that's why they presented to the hospital. That was the primary reason. Oftentimes it's a severe breathing problem that they're experiencing. But if somebody comes to the hospital, they happen to be COVID positive, but that's not what brought them to the hospital, then we will code COVID as a secondary diagnosis along with diabetes and congestive heart failure, any other things they might have had. But the primary diagnosis, it might be congestive heart failure, it might be, the hip fracture, it might be something of that nature. So unfortunately, anytime we do have a death of any kind where the patient did have COVID, we have to report that to the county, and who then reports it to the state. And so it's quite possible that when I say 16,639 COVID-related deaths, that could be death of all causes, but if they had COVID, it's considered COVID positive.
Even if it's secondary.
Even if it's secondary, yeah. So that translates to about 1.9% of the people that test positive, those 855,000 Californians that tested positive, about 1.9% of them end up dying. Or another way to look at it is 42 deaths per 100,000 population. I reported during the town hall meeting that I think in the most recent flu season across the United States, it was as low as maybe 8 deaths per 100,000 to as high as 15 to 17 deaths per 100,000 dying for flu-related or flu-affiliated causes. So definitely the death rate for COVID patients is higher than the flu, and again, the predominant reason is because of vaccination for flu and no vaccination for COVID. There are currently 2,239 COVID positive patients that are hospitalized right now, and we continue to see about a third, although it has dropped down to 28% of them are in the ICU. So we definitely are seeing a lower hospitalization rate across the state. So, but positivity rates, again, have been declining as well. But I think it's been some time since we only had 2,200 COVID patients in California hospitals. Everybody asks me about healthcare workers not immune to contracting the virus. So we've had roughly 42,000 California healthcare workers that have contracted it over the term of the duration of the pandemic. So of those 855,000, interestingly, a little less than 5% of them were healthcare workers. So we tell people, hospitals might be the safest places you could be to not contract COVID because of all the PPE we wear, the massive decontamination and sanitizing, and I'm trying to, too big, sanitization, that's probably not even a word, I don't know. Anyway, so yeah, so that's what we're reporting at the state level. Coming down to the county level, the county has now tested, and that includes tests performed by Quia Delta or Sierra View or Just the number of tests that have been performed on Tulare County residents now stands at 147,000. 17,072 as of this morning have been confirmed positive. So that's a cumulative positivity rate of 11.6%, which is about twice as high as the 5.2% that the state has seen over the duration of the pandemic, which is why Tulare County has been considered, one of the hot spots. I think we still rank fourth out of the 58 counties in the state in terms of having one of the highest positivity rates. Unfortunately, we're still in the most restricted, widespread infection, Tier 1 purple, because of our positivity rate and high number of cases. But like the state, our positivity rate has been coming down at the county level. So our 7-day positivity rate for Tulare County is down to 5.8%. That's one of the lowest levels that we have seen almost throughout this entire pandemic. So I just want to commend and applaud the residents of Tulare County for doing everything that they've been doing to help stop the spread of the virus. 95% of those 17,000 that contracted the virus have recovered from it. But again, that's a relative term. Some have fully recovered with no lingering symptoms or effects of it. Others have had a more difficult time and still are experiencing some of the lasting effects that we hear about for people that have contracted the virus. Over the duration of the pandemic, we have seen 274 total deaths throughout Tulare County, again, COVID related, and that translates into 1.6%. So we actually have a slightly lower percentage of people that contract COVID that die of it in Tulare County, albeit 1.9 at the state versus 1.6 at the county. But if you look at our population, so again, number of deaths per 100,000 people, the state at 42 deaths, Tulare County is at 56 deaths per 100,000. So while we have a lower percentage death rate in terms of the actual population, we have a higher rate of death. About 44%, 119 of those 274 deaths relate to patients of nursing homes. So I know that's something that people have been interested in. So the positivity rate, 5.8%. I'll just quickly, I know I'll talk about this a little bit later, but the governor's blueprint for a safer economy, for opening up the new 4-tier system that was implemented, Tier 1 going to Tier 4. Tier 1 is the most restrictive. Tier 4 is the most open and unrestrictive. So right now we're in the most restricted, again, Tier 1, purple tier. To move into the less restrictive, it's still called substantial, you have to have a positivity rate for 2 consecutive 7-day weeks of less than 8%. So at 5.8%, we're well below that 8%. And so from a positivity rate, we'd actually qualify for Tier 2 red. However, the other metric is those number of cases per 100,000. So not deaths per 100,000, but daily new cases per 100,000. So for us to be in the red tier, we actually have to be at about 34 daily new cases per 100,000. And again, you have to average that for 2 consecutive weeks before you can move into the next tier. And unfortunately, they take the most severe, the most restrictive. So while our positivity rate would move us into red, our number of new cases per day keeps us in the purple. So you have to take so if you want to move into red, you have to meet both of those metrics going in. And unfortunately, we're, over the last 7 days, Tulare County is averaging 44.6. So higher than the 34, about 32% higher than what we need to be achieving. And unfortunately, Doug Leeper, our Chief Information Officer, he's again kind of our COVID statistician, but every day he sends us an email about the number of new daily cases that are reported by the county. They come out every morning, and his email this morning said that Tulare County reported 57 new cases, so certainly significantly above the 34. That's what they reported this morning. Yesterday, they reported just 39, so that was encouraging. We got excited yesterday, but then hear about 57. But the day before that, it was 86. So over the last 3 days, 86, 39, 57. So we just can't really seem to get a handle on that. And that metric really has nothing to do with the amount of testing you're doing. Positivity rate definitely affected by testing, but the number of new cases, the only way that you really drive that number down is you drive the rate of infection down. Just fewer and fewer people become infected, and that really becomes, that's related to the behaviors that we all exercise. And then lastly, ending up with Cahuilla Delta, this is the real positive news. For the last probably 3 to 4 weeks, the number of COVID patients in the acute medical center has continued to hold really steady at about somewhere in the high teens to low 20s. So this morning at 6:30 a.m. we reported that we had 20 COVID positive patients in house. 11 of them were on a medical surgical unit, 2 South, which is kind of our dedicated respiratory unit. We had 7 that were on 3 West, which is an intermediate critical care unit, so between intensive care and medical surgical. And we only had 2 COVID patients in the ICUs. And both of them were on ventilators, but again, that's probably the lowest level of COVID positive patients that really required that very intensive care. Our 14-day positivity rate is just slightly above 6%, so we're real close to the county's 5.8%. But the hospital continues to be incredibly busy. Today, we're at 88.3% full. That's our occupancy rate from an adult standpoint. When I look at the 43 intermediate critical care beds that we have available on 3 West and 5 Tower, there's only 4 beds that are open. So we're taking care of some really sick. Non-COVID patients. We have 41 intensive care beds between 2 West and 4 Tower. So of those 41 ICU beds, we do have a little bit more breathing room. We have 15 of them are open. So we do have capacity in the event that we had more intense COVID patients or sick or injured patients that really required, that intensive care. And then lastly, over this pandemic, we've had 378 of our employees that have contracted the virus. And I'm delighted to report that 349 of them have recovered. Most all of them have returned to work. We only have 29 of our employees that are still out on leave because of COVID. So, yeah, so kind of a mix, of predominantly, I think, good news and certainly what we're experiencing here right at Cahuilla Delta.
Right. I remember when we were just watching that positivity number, and then they added that case per 100,000. It's like,
yes, yeah. Well, you also remember positivity number, we were above 20%.
Yes.
And
yes.
And that was obviously making us very anxious at the time.
Right.
But it's been great to see that it's come down so much.
So this question came in yesterday. What are the ages of the last 8 people who have died at Cahuilla Delta from COVID?
Yeah, so people are trying to stump me, throw some interesting questions at me. So I will read them off from youngest to oldest. This doesn't necessarily correlate to, the when they died. So just youngest to oldest. So of the 8 people that have passed away at Cahuilla Delta from COVID, the most recent 8 people, The youngest was 48, then 51, 58, 65, 67, two people that were 80 years old, and the oldest was 88. So obviously a pretty broad spectrum, which is what we have been seeing throughout the pandemic, that the vast majority of the deaths have related to folks that are 65 years and older, who tend to have more underlying, chronic conditions. But we have seen young people die as well. Oftentimes, if not entirely, that they also have had, uncontrolled diabetes or hypertension or something of that nature. So.
Okay, thank you. So now that our positive cases are going down in the hospital, when are we going to revisit our visitor policy?
Well, we are always revisiting the visitor policy. In fact, we've been doing that from day one. Because as I say often, that was the most difficult action that we ever had to take to protect our patients and our employees and visitors and doctors, was to really restrict visitation. We've always had, the exceptions in place for end of life or developmentally disabled patients, or those that can't otherwise communicate for themselves, the birth of a child, things of that nature. But it's almost been weekly throughout the pandemic that we have evaluated, are we at the point where we think we can loosen it up? And that really, that point has just arrived, again, over these last 3 weeks. As we've seen the number, kind of hover steadily at that 20 COVID inpatients per day. About a week and a half ago, our command center, all our section chiefs, met, had a lengthy discussion. We have an actual committee that focuses on the visitation policy, and so we kind of put it on them to propose something that would reflect a loosening. So I'm delighted to report that starting Monday, 8 o'clock, this coming Monday, what is that, the 19th? I think so.
Yeah.
Yeah.
What day is it?
So we will begin allowing every patient that's in the acute medical center to have one unique visitor. The visiting hours will be from 8 a.m. to 8 p.m. Every day of the week in the acute medical center. I say unique visitor because we don't want, 10 visitors, one every hour, rotating in to see the patient. Because again, we're still concerned about limiting exposures. And again, it's because such a high percentage of people that are infected and contagious are totally asymptomatic. So they feel perfectly healthy, they look perfectly healthy, they exhibit no symptoms, but they're still contagious. So that's why we're still, we want it to be one unique visitor per day. Now, that doesn't mean that it can't be, a son Monday and then the daughter on Tuesday. It has to be, that single person that day. We will screen all visitors that come in, temperature and questions. They will have to, they'll be required to wear a mask, a surgical mask. At this time, we're not allowing visitation of COVID positive patients, unless it falls into one of those exception categories. If it's a patient that has COVID that death is imminent, or again, developmentally disabled or unable to communicate on their own, or they're going to undergo, kind of a very severe surgery like open heart surgery or neurosurgery. Even if they're COVID positive, we do allow visitors under those exceptions. The emergency department is, for the time being, is going to continue to be more restrictive. So again, from the beginning, we've allowed the charge nurse the discretion to allow a visitor back into the exam room with a patient. So that discretion has existed since really the beginning of our new visitor policy, but we're going to keep that restriction still in place. But we will continue to look to change that over time. At our South Campus, which is our 54-bed skilled nursing facility, both subacute and skilled level care, that was one of the units that was locked down very restrictively at the beginning. But beginning there on Monday, we will actually start allowing 2 visitors at the same time to visit in that skilled nursing facility. Again, full screening. Anybody that's exhibiting COVID symptoms would not be allowed to come in. But if you are exhibiting no symptoms, again, wearing a mask, allowed to visit throughout the course of the day. Now, because of the more congregate living of that and the more vulnerability of that population, we're not going to allow visitation every single day. So the visitation will need to be scheduled, through the facility, and it is going to be more limited. So it may only be 1 day a week. I think I don't know if they're going to start out 1 day a month. It's a longer term facility, but those details will probably be fleshed out between now and Monday. But 2 visitors per patient, scheduled, more structured, but not every single day. But definitely it's a wonderful change that is allowing more visitation. We definitely we believe that visitors play a huge role in helping patients heal, calming their anxieties and fears, which helps the body heal when it's not under tension,
Right.
but also helping the caregivers, helping communicate information, helping calm the patient and helping them listen. So it actually, this strict visitation policy is really negatively affected our ability to take care of a patient. So nobody is probably more upset by it than our nurses and our doctors, because they know the strength of visitation. So, and then lastly, on the West Campus, so our rehabilitation hospital out there, which has 45 beds of acute rehab, 16 beds of skilled, short stay skilled. They're going to stay still pretty restricted at this time. They do allow families to participate in training of acute rehab patients, but they'll stay a little bit more restrictive. But again, we're going to continue to evaluate. One of the things that I think we're holding off until October 26th, so 1 week from this coming Monday, is we will begin to allow a visitor to go into the surgical waiting room with a surgery patient and to go back with them in the preoperative space and to stay with the patient until they're taken into surgery. And then we'll continue to keep the visitor, the loved one, informed about what's going on. And then when they come out of surgery, to be able to go back to them in the post-surgical area and be by them. So that is probably one of the most significant changes, because obviously surgery is a very anxious time. And I know that some people have actually put off surgery, elective surgery, because they couldn't have a visitor and they didn't want to be in here by themselves when they were going to undergo surgery. So that change will happen on Monday, October 26th.
Okay, so that will roll right into the next question of, are we expanding our surgical procedures? Non-essential, non-emergent?
Yes, in fact, that is now done. There are no restrictions remaining in place on surgery. So that just occurred probably about a week ago. As the numbers have stayed down, as testing supplies have become more available, because we do test all elective surgery patients 48 to 72 hours before their surgery. We actually will soon start testing every surgical patient. Even those that are already in-house or in an inpatient bed awaiting surgery, or they need surgery, we'll begin testing them. But now there are no restrictions. So all elective surgeries, inpatient or outpatient, are now being scheduled by our surgeons. There's still a backlog,
Right.
it's still going to take a little bit of time to catch up, but all the ORs are running and surgery's back to full scale now.
Okay, so let's make everybody really happy. Are we opening Lifestyles?
No, sadly not. Gymnasiums are only lawfully allowed to open when a county is in Tier 2. So you have to be in Tier 2, and even when you're in Tier 2, you can only open up to 10% of your normal capacity. So we do know of gyms in Tulare County that are open, and essentially they're defying the governor's order. I don't know if I'd call that breaking the law. Laws are set by legislators, but it's an executive order that most everybody is following. Kuya Delta, as a governmental institution, as a public hospital, feels a responsibility to follow the governor's executive order. Unfortunately, that's what we're doing, and so that's why it's so important that we get to Tier 2, and we're on the cusp. I mean, we have that positivity rate. We just need to drive down the number of new daily infections and hold it there for a couple weeks, and then move into Tier 2 and open up the Lifestyle Center and get back to working out.
So if you're battling the quarantine 15, you need to wait a few more. Maybe let's just wait till after the holidays so that you can have
quarantine 15? What's that?
Quarantine 15.
that-
The 15 pounds you gained during quarantine.
Gosh. Okay, there's a name for it. Huh?
Yes, one of our employees had reached out to me about Lifestyles, and I said, "Uh-oh, have you gained the quarantine 15?" And he said, "It's more like the quarantine 20 for me."
Yeah.
So, just do the best you can.
Yep.
Okay, so let's talk about testing. We have rolled out rapid testing, I know, gradually. And right now, which of our rural clinics has the rapid testing?
Yeah, so we have the Quidel Sophia 2 antigen-based testing, which is the rapid result, detecting the proteins that rest on top of the COVID molecule. Produces results within 15 minutes. It's a simple swab of the nostril, not the deep nasal pharyngeal. So we have 20 of those analyzers. We now are up to, I think, 25,000 test kits. We now have fully deployed and are testing at our Exeter clinic, our Lindsay clinic, and our Dinuba clinic. Also out at Visalia Medical Clinic. Soon we will be deploying that to our 2 urgent care centers, the one in Northwest Visalia on Demarie, and then Court Street. We did just deploy it also to our family medicine clinic on the 5th floor of 202 West Willow. So we now have that testing capability across multiple sites.
Okay, not in Woodlake yet?
No.
Okay.
And I don't know if there's a plan. I have not heard Ryan Gates talk about deploying to Woodlake, and I don't know if that's because it's so, we actually had to, there's quite a bit of planning and infrastructure that goes into that. We acquired, fully HVAC equipped C-trains that were placed at those 3 different clinics and dedicated staffing to them. And perhaps Woodlake being so close to Exeter and being kind of a less busy clinic, that we decided not to deploy it there.
Okay. So there's still confusion about testing. Do we all run out and get tested? You said a few minutes ago that the mass testing does not drive the positivity rate up.
Mass testing does.
Mass testing does, okay.
Yeah, the positivity rate is obviously, the denominator is the number of tests you perform, and the numerator is the number that tests positive.
Right.
So there's a belief, that the more and more testing you do, that you're going to end up testing a lot of healthy, uninfected people. And so your positivity, the denominator goes up significantly, But if you're not detecting any virus, then the positivity rate's going to come down.
Right.
So
But then there's the argument that, well, if I'm asymptomatic,
you're going to test positive.
you're going to test positive,
Yeah.
and then it.
Right. And
So
that's
that's
the risk, is that,
Right.
hey, I'm going to go get tested. I feel great, but you end up testing positive.
Right.
That doesn't help the positivity rate, and it doesn't help the daily case rate either.
Right.
So, yeah, it is very confusing. And today, it still remains confusing. Not to add to that confusion, but with respect to the blueprint for a safer economy, opening up, moving through the tier system, unfortunately, the state, the California Department of Public Health, is only counting those tests that are performed on what's called a PCR or molecular platform. PCR stands for polymerase chain reaction. It's not the lateral flow antigen testing. It's more of a testing that has a high sensitivity. It's a continuous testing, constantly looking for the presence of the virus. It tries to detect the DNA of the virus itself, the molecule, as opposed to the protein that sits on top of it. So we have right now 3 PCR platforms: the BD Max, the Abbott ID Now, and the BioFire. We soon will be completed with installing the new PerkinElmer PCR platform. Can do 500 tests a day. Very high throughput. It's the same platform that the county runs at their lab in Tulare. It's the same one that the state is deploying to 25 different public health departments. So there's a belief by the California Department of Public Health that PCR tests are more sensitive, more accurate. And in some respects, there's a lot of people that argue yes. Although if you spoke to Randy Coca, our Director of Laboratory Services, and Randy he's a genius when it comes to this stuff. And so Randy would argue with you that, number one, he would say the PCR test is not foolproof. That it's not 100% sensitive. It can miss the presence of the virus and give you a false negative. But it is highly, highly sensitive because it continuously looks for the virus. And it takes about 2 hours to run a test on a PCR platform. But Randy would argue, as would other scientists, in fact, one of the most preeminent molecular biologists in California would argue that the PCR tests and the antigen tests are equally sensitive and are equally reliable. In fact, this molecular biologist conducted a recent study of 900 patients, swabbed them for a PCR test, swabbed them for an antigen test, and there was almost a perfect correlation in terms of both negative and positive. And so Randy and this molecular biologist would argue that antigen testing is just as accurate and that the state is wrong in taking their position to only accept PCR testing. And so I'm personally trying to, and Randy is, we're trying to push the state, working with our local health department. I've reached out to the California Hospital Association because the problem is PCR testing. There are many organizations, many hospitals that don't have those platforms.
Right.
They have to be performed in a certified laboratory. Usually it requires a nasopharyngeal test or swab, and the testing supplies of PCR have been very scarce. Only recently did we start finally getting some of the Abbott reagents and testing kits coming back. We now have 11,000 of them, but we were down, 3,000, and we'd limited only to testing our patients and our staff. So to only test or count PCR tests really, I think, is a limiting factor here. Again, the tests that we are doing in the clinics, those are the antigen-based tests. Again, we think they are highly accurate, but unfortunately, we'll still report the results of an antigen test to the county, who will report them to the state through the CalReady system. We have to indicate, was this a PCR test or was it an antigen, and on what platform was done. So that information will feed to the state. They just won't count them towards our positivity rate or the number of daily new cases. So if somebody is healthy but is still worried, or their employer is requiring that they get a test, and if they can't get a PCR test, we'll definitely test anybody that wants to be tested. Call our hotline, go to one of those 3 clinics, and if you want to be tested, we will test you. But we're just going to inform you that the state will not count this test. We'll talk to you about our reliability of it, our belief in it, but there's a risk that you could have a false negative. But again, that's a risk with both PCR and antigen. There's just a belief that the antigen-based test has a higher risk of producing a false negative.
And several of you have gone to, I believe, our Exeter clinics and our Dinuba clinics, and you have sent me feedback, which I give to our team. And so thank you for both the positive and the negative feedback, because that's the only way our team really knows what the community is seeing when you're giving feedback about signage or multiple phone calls. Thank you for sending that to us, because then we're able to change those practices and help you out. So just very interesting, though, that we now have all of those testing supplies in the state. We can't use them to even help our county get to the next tier.
Right. Yeah, and again, that will continue to change. When this PerkinElmer PCR platform is in place, and we're actually we're constructing a laboratory right now in our blue room. It's down in our basement in the medical center here. It's kind of one of our largest conference room. It's where our board normally meets, and right now it's being used as kind of a respite area for our staff to go down there and be spread out. There's a television and where they can have, take a break, have lunch, and so in a corner of that room we are constructing an area that will house the PerkinElmer laboratory equipment, and it's just down the hallway from our primary laboratory. But once that's installed, again, high throughput, 500 tests a day, an unlimited supply of reagents and testing kits, that you very well could see that becomes now the standard that we test everybody, including healthy people, that we can run it on that platform. We're probably still, I don't know, maybe 4 or 5 weeks away from having that in place. But we'll continue to use the Quidel platform. I think the thing, that's where the confusion and the frustration is. That is the platform that the state sent to all the nursing homes in California to test nursing home residents and nursing home employees every week, to make certain they were COVID-free. So it was good enough for the state to send to our nursing homes. It also, the federal government just shipped 150 million of the new Abbott Binax Now antigen-based tests, shipped 150 million. They're the little AG cards that I talked about, where you just a Nair swab, you rub it on the card, it mixes with the reagent, you get results in 15 minutes, it costs $5. So the federal government just shipped 150 million of them across the country. And neither of those, neither the Abbott Binax Now or the Quidel that the state shipped, will be counted. The results won't be counted by the state in terms of the metrics. So,
is it just California, or are other states taking the same stance?
I don't know definitively. My understanding, it's California only, although there may be there may be a handful of other states, but I'm not aware of any.
Wow. Okay. So I was asked about the health equity metric that is now on the state's COVID site.
Right.
So can you tell us a little bit about that and what we're doing to partner with the county to meet that metric?
Sure.
Is that now a guideline we have to meet?
Yeah, it actually is a third metric now. So we've had the two metrics when the governor rolled out, again, the blueprint for a safer economy. It had the two metrics and the 4 tiers and everything. But the concern is that by the governor and the California Department of Public Health is that there are areas within counties that have been disproportionately affected by COVID. In the more socioeconomic challenged areas where they might have less access to health care, other demographic factors, less access to testing. They might have more congregate living because they tend to be more impoverished areas. So there's been a concern that while a countywide might show a good positivity rate, a low positivity rate, that the positivity rates in these pockets of counties are significantly higher. And so this was a way to address that disparity that exists, because you want a declining infection across all communities, across your entire county. So that's where this healthy equity metric came in place. It went into effect on October 6th. So again, it is now a third metric. And basically, what you do, there are 78 census tracts throughout Tulare County. And every one of those census tracts is assigned, and this is true of all 58 counties. So the state of California is made up of thousands and thousands of census tracts, the same ones that I think are used by the United States government in conducting the every 10-year census. It's done by census tracts. So Tulare County has 78 of them. Every one of them has been assigned what's called a Healthy Places Index. And there are 25 different socioeconomic, lifestyle, health factor measures. 25,
based on where you live.
Yes, so that determines your Healthy Places Index is where you fall within all these 25 different measures. So you're assigned an index. And so you take those 78 census tracts throughout Tulare County and you divide them into quartiles. So 4, 4, 4, and 4 quartiles, and you put 19 or 20 of the census tracts goes into each of those 4 quartiles. You take that lowest quartile, the quartile that has the lowest 19 to 20 census tracts, they have the lowest Healthy Places Index. They scored the poorest on those 29 or 25 socioeconomic factors. So it's believed that those roughly 20 census tracts, have the least access to testing and care and treatment and tracing and all of that. So now, to move into the next tier, not only does Tulare County have to have a positivity rate countywide of less than 8%, but also the overall positivity rate of those 20 census tracts that are in that lowest quartile, they must also have a positivity rate of less than 8%. So you have to now meet both of those. So you could have, right now, Tulare County has an overall positivity rate of 5.8%, but the lowest quartile census tracts have a aggregate positivity rate of 8%, right at 8.0. So it kind of affirms the state's concern is that overall a county could have a really low positivity rate, but in its most challenged areas, it's many times its most impoverished areas, that the positivity rate is much higher. In fact, the county reported, or the state reported, that when it looks at its census tracts that fall in the state's lowest quartile, it accounts for 24% of the state's population live in those census tracts, but they account for 40% of the total positive COVID cases. So that 855,000 positive COVID cases statewide, 40% of them have occurred in those census tracts that only account for 24% of the state's population, because they are more socioeconomically challenged. So there's some merit definitely behind that. So immediately when the governor and the state issued that healthy equity metric, Ryan Gates, our director of or vice president of population health management, reached out to Tulare County and immediately began collaborating on how do we work together to go into those areas, those lowest quartile census tracts, and provide testing to them. So we actually have an event that's occurring on October 24th. It is being really led entirely by Kaweah Delta, not the county. So Kaweah Delta staff, Kaweah Delta testing supplies, we're going to be running it on the Abbott ID Now platform, the PCR platform. We'll be testing on that platform so that we get credit with the state. But it will be held at Neighborhood Church, and it's a collaboration with folks in the Goshen area, Houston Elementary School, Neighborhood Church. So kind of I don't know if it's all day, but you have to call and schedule. This is going to be kind of our initial outreach into the lower quartile census tracts. We hope we get a good turnout, but we are working with the county on developing future, fairly near future testing days where we can go into those other communities. Now, there is another way besides to be able to open up your your businesses now, your county, is you can still be above the 8% as long as you've submitted what's called a plan of investment. So the county is preparing that right now, that you can demonstrate everything you're intending to do, to go into those communities, to increase testing, to increase tracing, to everything you can access to, care and diagnoses. And so if you have a carefully crafted plan and you've shown how you're committed the funding, committed the resources, and you submit that plan to the state can approve that plan and say, okay, you meet these other two metrics, you're below the 8% positivity rate for the entire county, you're below the average daily new cases, you're still over the 8% for your lowest quartile, but we like your plan, we accept your plan, we'll let you move into Tier 2 now, even though you haven't hit it in the lowest quartile yet.
Yeah. That seems really difficult, though, to target certain areas and for them to turn out. Because if you open up a citywide testing thing like at Neighborhood Church, you're going to get people from all over,
Right.
So how do you guarantee that it's...
Yes, and remember, these are roughly 20 census tracts. How big is a census tract? I mean, we're trying, and oftentimes the census tracts are contiguous, that, you don't generally find one census tract that's very impoverished that's surrounded by an affluent, neighborhood. I mean, they tend to be kind of clustered, those lowest quartile census tracts. So, you try to do it at the epicenter of those census tracts, and you're primarily drawing from the people that are living in that area. But if we draw people from the outside, I mean, that's fine too. I mean, we want to test more and more people. We certainly all wish, we're disappointed that the antigen-based tests are not being used, but we do intend to go into these communities, and again, it will be largely driven by Kaweah Delta. We've kind of made our commitment to our county, our community, that we're going to be a leader in helping our community work through this pandemic.
And we want to make sure that everybody knows that everybody has access to our health care.
Yep.
Yeah. All right, Gary, well, we have just a few minutes, so if you want to
Wow.
just, yeah, I know. Before I let Gary close this out, though, I'm just going to remind everybody that this video will be posted on our Cahuilla Delta COVID-19 page. And we also, not only do we post the video, but we post the written questions and answers. So if you're confused about something that was said today, go back and look at those written answers. And then, of course, you can reach out to me if you have any further feedback or comments. So would you like to do the honor?
Thanks, Deb. Thanks to all of you, our community engagement partners, and again, express our gratitude and appreciation to all of you for sticking with us throughout this pandemic and staying very engaged with us. And as Deb said, we greatly appreciate your feedback, both positive and negative. We're a learning organization. We strive to continuously improve and become better, and we really can only achieve that by listening carefully to you. And so definitely always feel free. We're accessible by email, phone, drop us a letter, a line, however you want to communicate with us. And thank you for keeping the questions coming. Our intention is to continue to hold these, moving to bi-weekly now. We're also actually, I chair the Hospital of the Future Community Advisory Committee, and I think we have our first return meeting scheduled for the first part of November. I think November 5th or on that. I think it's a Thursday after Election Day, actually.
Yeah.
But can't wait to update you on, despite this pandemic, we're still moving ahead with so much planning around future facilities and renovation, and talk to you about the ED expansion project and the Mineral King Wing. We've actually done now some of our core testing of the concrete and have the results back on that. And so just anxious to share all that information with that committee and in fact all of our folks. So just thanks again. We greatly appreciate your support, and I hope you guys have a wonderful weekend. Thank you.
Thank you.